wanted to begin by just saying a little bit about what this lecture is. It's held annually in honor of Christian Vera, was endowed through his pupils. Dr. Vera was born into a very old Chilean family whose ancestors were conquistadors, and they've been there for about 500 years. His father went to Princeton and was a linguist, came back to Chile, and so he came from an academic family. They initially thought Dr. Vera would be a concert violinist, but Dr. Vera says around age 18 or so, he realized he was not the best, and that he only wanted to do it if he would be the best. And so he found another passion, and he became fascinated by the neurosciences and began doing a lot of neurophysiology research that led him, at that same time, the Rockefeller Foundation was providing grants throughout the world for people to advance the neurosciences. So Dr. Vera wrote to them, received a grant, and went to the Montreal Neurological Institute and was studied there for many years. He was a pupil of Wilder Penfield's, and I've been told he was the resident scrubbed in with him on his last craniotomy. Dr. Vera worked with Herbert Jasper, Elizabeth Crosby, and became very good friends with Fanner Perot, who later became the first chairman here at MUSC. Just like you said, you never know who you're sitting next to. So the two of them there, they revered Penfield. They heard all about Sherrington, Ramon Cajal, and all the pioneers. And from then on, Dr. Vera has been most interested in the basis of human consciousness and how, in particular, what neurosurgeons can do to help the human condition, which is a big question. He ultimately went back to Santiago, chaired the neurosurgery program there at the Catholic University, but politics was difficult there. He immigrated back to the US, and Dr. Perot hired him here at MUSC. And together, for about 30 years, there was a kind of Montreal Neurological Institute of the South happening here, where 30 years of continuous NIH funding for somatosensory evoked potential research, especially in spinal cord injury. Dr. Vera has never really been motivated by monetary parts of medicine, and he certainly doesn't care about RVUs. He's just been very passionate about inspiring the next generation because he himself was around people like Penfield who were so inspiring. And he feels very convinced that neurosurgeons have a key role in making the future better than the past. And with that, he's always treated us as the residents like his own family. Unfortunately, his health prevents him from being here today. And so we'll give him an account of everything, after today.
That's a beautiful, can you go back to that slide?
Yeah.
You remember the Paul method? That's Anita Mansfield, the patient, and she's crying because Dr. Vera has really touched her life. I think she was born with, some anomaly, and she's functioning now. And Dr. Patel and Fraser, you seem to be behind the scenes here, but always the catalyst there. You're in a lot of these pictures, whether you're photogenic or just really the spark plug, as you were at Penn, So I noticed this picture, and I have it too, and I'll treasure that picture. And I am sorry, Dr. Vera is not here, but he's here in spirit, and it's an honor for me to have this lectureship to my, as one of the events in my CV. But it's more than that. Actually, when I was a resident and I was looking for my first position, I was interviewed by Fanner Perot. That's my fun fact and secret that I'll tell you. And what I was very impressed with, besides the pedigree, was how they had this work balance. In the old days, back those, it was like, how do you integrate your research or your expertise with your practice? And Fanner Perot had a system where you'd be on call and just work night and day for 2 weeks, and then you'd be transferring to someone else who was coming on, and you'd be doing the shunts and things like that after your craniotomies. And then you'd have 2 weeks, not of protected time, but, devoted to the academic teaching and writing and grants and so on. So I thought that was a very appealing system. Then I was invited to head a unit up in Montreal that was attached or linked to MNI. So I went right to the motherland there. But so all of this does resonate with me. Thank you.
Well, yeah, that's a cool connection. And and you've taken a little bit of my about you. Looks like we just need, okay, good. So last year we invited Dr. Brem to be our speaker, and he graciously accepted, not knowing whether we'd be here in person or whether you'd have to imagine Charleston from a distance. Unfortunately, it is the latter. Charleston has changed a lot since you mentioned coming down with Perot. Yeah, that's how it looks every day. When you were, many of you may wonder why Dr. Brem became a neurosurgeon and not president. As it turns out, you were born overseas, coming to the US as a young child. Part of a remarkable story everyone will have to ask about another time, but the story is documented in the congressional record. Remarkably, Dr. Brem's brother is also a decorated academic neurosurgeon. After growing up in New Jersey, Dr. Brem graduated magna cum laude from Rutgers, went on to Harvard Medical School, where he stayed for internship and residency. Even as a young medical student, your career was on a trajectory balancing medical school with working in the lab of Judah Folkman, who was a renowned scientist who pioneered the field of angiogenesis. We may hear more about that in a little bit. From medical school, you went on to the NIH, serving as an officer in the US Public Health Service before going back to Boston for residency, and then went on for a fellowship with Russell Patterson at Cornell in New York. And like all Harvard-trained neurosurgeons at the time, you knew you couldn't just take any job, you had to lead a program. So you went over to be neurosurgeon-in-chief at Sir Mortimer Davis Jewish General Hospital, faculty role within McGill, and also consulting at MNI. A couple of more important things happened in Canada, and there I believe you really solidified your reputation as a medical educator. I've walked around with you at national meetings, seen people come up and talk to you about the role you've had in developing their careers and how contagious your enthusiasm for science is. In Montreal, somehow you blended busy clinical practice with a research agenda on the nights and weekends, all part of that work-work balance. More important development in Montreal was meeting your wife, Hannah, who she translates French language for senior government officials, and she paints prolifically in her spare time. So from Montreal, Dr. and Mrs. Brem moved to Chicago, Northwestern, in order to catch the last part of the Michael Jordan era. 5 years later, Dr. Brem was chief of neurosurgery at Moffitt Cancer Center in Tampa, a small program that has now become a top-ranked cancer program. Before you were recruited back by Sean Grady to the Ivy League, and where you co-direct the Penn Brain Tumor Center. In Philadelphia, I can tell you Dr. Brem gets some of the highest accolades of any professor by the medical students, and the residents admire you greatly. In part, I saw it because, as you mentioned earlier, I think you do treat all the residents as future colleagues, and you often introduce people as the future chairman or chairwoman of neurosurgery, and you say that you have to respect them as such. Your colleagues remarked to me several times they found it humbling as well to often be taught about the newest and latest neurosurgical technology and treatments, even though you're their senior partner. As a research fellow, I learned a lot at the bedside with you. You take a lot of time, individualize a plan for every patient, and I really admire, in particular, the way you attend and co-lead every single brain tumor conference, which ironically we're keeping you from today, unless you're out of town. And similarly, like Sean Grady, attending every grand rounds, you're always there in the front row, and you're at every resident lecture, also in the front row. So that's a little bit of a short introduction to our speaker today. Here's a book you published recently on glioblastoma. And please take it away, Dr. Brem. Feel free to share your screen, and I'll interrupt you with questions.
Thank you very much. It's besides the honor of giving this lecture, and it was an immense honor to have you come to Penn, and you left your imprint there. I also wanted to say, since you mentioned brother, family, my wife, and the neurosurgical family at Penn, you have quite a good pedigree yourself, and Fraser Henderson Sr. is a force in my life. As I went up to Georgetown on a mission with the leadership at Moffitt to select a radiosurgery system, and your dad was a pioneer in CyberKnife, as you know, on the East Coast. I think he had the first unit. He's expert in spine, but also the philosophy of one of our Penn surgeons, Ernie Rosado, was that every surgeon should be a surgeon in something else. And he was also very interested in biology of tumors, thought about inhibitors, got Defense Department grants, was very innovative, and actually came to Moffitt to serve on the advisory board of the National Center for Functional Genomics, which is really outside the box of someone who day job is an authority on craniovertebral spine reconstruction. So your dad was at my son's bar mitzvah. He's a friend of the family, and what a great honor. And I know that you have the neurosurgery DNA. So thank you, Fraser, and thank you to everybody at MUSC. So let me start my formal talk. And the topic was a little unusual because when I spoke to Fraser, I said, do you want me to go over all your papers, or how shall I, because you left this big footprint at Penn. He said, why don't you give us your perspective on the field, since you've been doing it for quite some time. And so my wife may be listening. I said, well, maybe I'll talk about the last 10 years at Penn, or the last 20 years of running a brain tumor program, or the last 30 years of academic surgery, or the last 40 years of being in the lab and training with Judah Folkman. And that's quite a long, she said, that's quite a long time. And then I saw the newspaper that Joe Biden is ending America's longest war. And then it hit me, this would be a great theme and a good topic, because the longest war is, literally, there are two meanings of the war. One is the classical battlefield and with tanks and missiles, and then the other is our concept of a war as opposing forces, like war on poverty with rich and poor, or the war on cancer. So I'm going to start with this screen share. Are you seeing the right?
Yes, I can see your first slide, current tactics.
Okay, good. All right. So, and now there seems to be a new surge with technology and immunology, and looking at this from this historical personal perspective as well, and seeing that we know so much more than we did when I was a student working with Judah Folkman. So again, thanks to Dr. Patel, thanks Dr. Spiotto for supporting us and sending Dr. Fraser Henderson to Penn. It really has made a difference. And I do intend, I notice we're on the Schuylkill and Delaware Rivers. I do intend to come down here, Broad Street and Ashley Avenue, and pay you a visit. So let's start out with a patient. Can you see all this okay?
Yeah, it's coming through great.
This is on that theme of earlier diagnosis. And here is a 29-year-old woman. She's in the Philippines. When she was 24, she had these fainting spells. No one knew exactly They thought it might be neurological. They got this scan and they just saw this little thing. They ignored it as a nothing burger. I don't think that was the word in the report, but it was something like that. And then they also got an MRI and they said this is probably of very little significance. So here's what happened. She then developed this monster tumor. You can see it's quite angiocrotic, mass effect, and has amoeboid appearance of a high-grade glioblastoma. She was treated at a fairly sophisticated unit in Philippines. I'm going to use the name Susan Dell as a pseudonym to protect HIPAA, protect her privacy and comply with HIPAA. But they did some nice tractography. They had advanced navigation. I guess the surgical philosophy was first do no harm. So they did went through the superior frontal sulcus and did basically a biopsy. They reported it as a biopsy. They took out about 2.5, 3 centimeters. The pathology was very grim, as we're going to see. So there was a Wharton connection, and with Dr. Grady and the Department of Neurosurgery. So they were thinking of going to Hugh Dufault to get a very radical resection. So that decision also informed my thinking that we could do that because before coming to Penn, I spent a day with Hugh Dufault, and it was also very transformational to see what a very well integrated team he has with the weight craniotomies and see his method of subpeel dissection. And so I thought we could do similar. And one thing, and as you know, Dr. Henderson, we use a lot of image guidance, and we use we have some very advanced tractography, and influenced by the work of Michael Chagru on connectomics, I asked our radiologist to segment out the frontal Aslan tract because given this location, I was very worried about SMA syndrome. And earlier when I went to Penn, I would do this with the patient asleep with standard tractography and follow the tumor into the corpus callosum, but that can result in an SMA syndrome. So here it looks favorable in that this tract, if you look at the opposite control, is in the superior frontal gyrus, but here it's pushed back. So we weren't necessarily going to do a radical removal, but we were going to do maximal safe, and she was awake for this operation, a very brave woman, and so we went ahead and did this. And here's we found a true keyhole flap that they did for the biopsy. We extended it. You could see from less than 3 centimeters to almost 7 centimeters. So this was not going to be minimally invasive, but hopefully maximally effective and minimally toxic operation. And we did mapping, and sure enough, we did get positive signals on the posterior margin, but most of this, the superior, middle, inferior frontal gyri, and the previous incision site were all in full view, and the tumor was, of course, resectable. And then we got this immediately post-op, and I just followed the tumor, and I thought, oh my goodness, I've taken out the caudate. Don't aim for that, but I just aim, for the tumor. But she's completely fine, as you'll see. So this is a very big decompression. There's some extra axial fluid, but she looks very good. And here's Susan with her arms up and feet off the bed. And there's a little movie, and I won't show it to you, but her first words were, "I'm normal, Dr. Brem, and I have my memory intact," and so on. So she was very happy. During the operation, her speech got a little slow and she got a little weak on the left side. So I thought we could stop there, but we got about 97, 98% of the tumor out. Unfortunately, the tumor is very high grade, and if the Ki-67 is over 67, it's 80%. So that's a round cell variant. It might be the H3G34 variant, and it's being sequenced now at CHOP. But clearly, she's going to get standard proton and temozolomide in the Stupp protocol. But this is a tumor likely to recur and likely in need of anti-angiogenic or immunotherapy. So unfortunately, her IDH now is wild type, and methylation is the promoter is unmethylated. So it's a nasty tumor at the cellular molecular level. So I was going to talk about some of the themes, which is the longest war. You know, one of the famous quotes that if people would not realize how much they could achieve if people give up when we're really on the 2-yard line. And are we on the 2-yard line? It always feels, for the last 40 years, always feels that we're on the verge of a major breakthrough. And now we're in the era of CAR T cell and many immunotherapy vaccine trials. And it does seem like that we're on the verge of a sustainable major breakthrough, as we've seen with brain metastases. Fraser, you know, you were in the clinic, and when we see patients who have had melanoma to the brain, they're very bored and happy to go to clinic. Their scans are clean, as in contrast to the glioblastoma patients. So can we turn these tumors that are immunologically cold into hot tumors? And of course, we've talked about student and resident days, and you'll hear about immunorevolution and the surgical technology, the extended resection. Fraser, this is another one of the incredible things that you did while those 6 months. You attended the Subcortical Surgery Society and forged this link between Penn and Michael Shagru's team out in Australia, and they came over, and we have a draft protocol now, and 6 or 7 centers, and we're actually going to have a symposium with the Society of Neuro-Oncology later this year in November, December. Right now, it's going to be virtual, but it'll be all on connectomics, and you helped spark that collaboration. So thank you again for all the things you've done. Innovation through collaboration is the way we as surgeons are very devoted to individual patients and all the details of planning and post-op care. It's really the only way we can succeed. And we are unique in that we're the only group that has access to the OR. So we are doing viral therapy trials, we're doing immunotherapy trials, we're doing work on single cell as an assay in transcriptomics, and the OR really is the laboratory. And so we're developing biomarkers, and we have to realize what the barriers are to progress and tactics to win the war and overcome those barriers, because these are the same barriers that have been around for a long time, but I think our tools are more sophisticated. So hopefully we're going to have the ultimate answers with this. And it was in 1971 that Richard Nixon declared this war on cancer, and ironically, Ted Kennedy, who later died of glioblastoma, of course, was there, and Democrat, Republican. I mean, this was a great moment in his legacy, and the woman behind it was Mary Lasker, who is just very, she's a philanthropist, but also very down to earth. Why aren't we uniting and getting the best minds to work on this problem? So speaking of best minds, I think this is a lectureship in reverse. I wanted to tell you, Fraser, the check is in the mail, and that we're going to be sending you your certificates and here. So I wanted to talk a little bit about Fraser again, and by not what a great guy is, but what his productivity. So he came here, it was sort of like a blank space, you know, like Taylor Swift, here, blank space. Yeah. Yeah. I discovered her by, her mom looked this up, had a brain tumor, and she said it was not like nothing else in her whole life. So in terms of quality of life and cognition, so look it up. Anyway, here, so this is the paper that's just out this week, which is really the fruits of our work with Dr. Verma and through her NIH grant, and it really represents a practice-changing technology that came through our through the NIH and through Dr. Verma. And I, as a surgeon, just was co-PIing this to validate. And we're in a unique position as surgeons to take the science to the next level and to apply it to patients. So this is your paper on flucyclovine. After this lecture, I have a patient that we're using on for a phase 0 clinical study looking at an anti-GITR, but we're going to use this as an imaging biomarker. So this was just great work to harness all of the science at the university and put it to print. And this is our commentary on LIT, which is another technology, sort of another talk. And this is ICG, which has been championed at Penn by John Lee. And this is the molecular correlates, which you were a key author on in terms of survival. And then this is a broad review for neurosurgery focus with Dr. Abdullah and Dr. Verma. And this is on 5ALA and really an editorial on how much technology is optimal. So this is just part of your work. The most of the rest of the other papers are on my desk, but I'm sure we'll next year it'll be 14 papers for the 6 months. You didn't waste any time, that's for sure. So I thought that one of our commentaries was sort of an opportunity to present something that I think of a lot in assessing new technology is when we get very excited with a new technology, be it intraop MRI or ICG or whatever, it really sounds phenomenal, and there's these peak of inflated expectations. We get very excited, and then we see that there's downsides, or there might and it's off of disillusionment, and then start to see specific applications, and then there's this plateau of productivity. So this is the way it's been with immunotherapy. Back in the 70s, I was working and published what is arguably the first paper on cellular toxicity, showing that lymphocytes from another patient could kill a brain tumor in vitro. And Steve Mahaley in Carolina, I know it's a different state, up a little north of Boston, but Steve Mahaley devoted 10 years of his life at Duke and then North Carolina to look at immunotherapy and wrote some classic papers on it. And we thought at that time we were getting close to a vaccine. But then there was this trough of disillusionment, realizing IL-2, Paul Kornblith was my mentor, and he was head of NCI before Ed Elfeld, NIH Neurosurgery, and he had worked with Steve Rosenberg then now Steve Rosenberg is working on CAR T-cell with our team. And IL-2 looked great, but stimulated the immune system, but also was very toxic. So then there was this little trough of disillusionment with immunotherapy, but now it's come back with the discovery of checkpoint inhibitors and tremendous work that has changed the oncology landscape. So checkpoint inhibitors are part of our IL-6 trial, which will open up this summer. And then another one of our commentaries allowed us to look at how much technology is really good. And, you know, should you have ultrasound and intraop MRI? What we have at Penn right now is detailed DTI and connectomics, if you will, image-guided, the microscope. We'll do intraoperative mapping, we'll do wake mapping, and we'll do fluorescence. So in this paper that we drew this sketch, the group in Italy had shown that with multiple surgeons, the ones that were using combined technology had the best outcomes. It kind of makes sense, but not necessarily that way. But so we all love technology. When is enough enough? And so this is work from John Lee, and Fraser. You know, we always have this very serious picture of John who looks great, and he's done great work in really promoting fluorescence, and he'll be at our symposium with Kostas Hadjipanayas, who introduced 5-ALA. And then behind is the famous Agnew clinic at Pennsylvania Hospital, where John is. So, and this is you know, I've done over 5,000 craniotomies for tumors, and some, well, Eileen Maloney, who's at the heart of all of our research, said, really, Dr. Brem, you really need this glowing tumor? I mean, you can't find a tumor. And I said, well, let's give it a try. And I love innovation. I love new technology. And I really like this test because there are cases where we're not sure at the margin. And this does demarginate the tumor. And this is one of your publications, Fraser, about lymphoma. And this is ordinarily a tumor we just biopsied. And here, in this case, we went after it to debulk it. But here in vitro, it just looks like tissue, and here it lights up. And one of our surgeons, Isaac Chen, has done this very useful for biopsies, stereotactic biopsies, where you're not sure you're in the lesion, there's this flare, you're not sure you're at the edge, the pathologist is not sure, is it gliosis, you don't want to miss a tumor. Well, if you use fluorescence and it lights up, you know you're on the lesion. So I think that's one of the very good uses for it. And again, this is your paper where, and we'll be coming out with a larger paper, but first two cases where you can use flucyclovine PET, that's a separate procedure, pre-op workup, but it can light up the tumor, light up the active areas. And we validated this with histology, and both Dr. O'Rourke and I have used this, and we'll fuse it into the navigation system so that we can localize the hotspots. And I'm pretty sure this will get FDA approved. And so, again, this has been a very, very important translational work. And now we're extending this to metastases, but its mechanism is the flucyclovine is it binds to an amino acid transporter, which is only found in active dividing and actively metabolic cells, and not, of course, in necrotic tissue. It is FDA approved now for prostate cancer, where a similar clinical dilemma, where if someone's been irradiated, and they have swelling. Is that pseudoprogression or progression? So we're continuing in that way. Well, this is the paper out this week, and I wanted to acknowledge our research partner, Dr. Verma, who's made landmark contributions in the human connectome, autism. She actually helped identify a disease that hadn't been described before, and this was electromagnetic energy being beamed at our workers in the American Embassy in Havana, and had a bizarre neurological condition, and she looked at the connectome, described that in JAMAs. Work on brain tumors, and this is, she has a lab called the Decipher Lab, which looks at diffusion, and it can generate a connectome. And this is one of our papers where we emphasize that around every tumor, there's an individualized signature and a safety zone around that. So in your work, you looked at standard tractography. This is the Western aphasia battery, and all of these patients were fairly fluent. But when you looked at your tracks like IFOP, before you had the Verma, it's called a FERNET, actually it's an acronym for free water correction for tractography. All you can see is 2 fibers, but when it's corrected, you can actually visualize it by, you can see 612 fibers. And here also fiber counts go up on this other patient. So it went up for almost every patient, and you had clarity. When on all our radiology notes, when we do tractography, Dr. Wolf writes, and everyone's adopted this, everything that's functional is not visualized, and everything that's visualized is not functional. And so trying to decide which tract is key, and are there any missing tracks? So we think this is going to give us a new level of clarity, specificity, sensitivity, and clinical relevance. So we're excited. This is a standard FLAIR. You can see the patient selected had this edema, which for primary brain tumors is infiltrative edema, is where the microscopic disease is. And then quantitatively using the FERNET, there was increased fiber count, and you could see the tracks longer and more of them. Before this understanding, I would go to the Subcortical Society with AANS and CNS, and there are posters how neurosurgeons, how we actually restore pathways by doing surgery, and the pathways start to reappear, and it's not really a connect. They're really not growing new fibers, of course. We're just being able to see them because the edema is gone down. And this has been a big problem in diffusion tractography, because free water, that's how you detect the eigenvectors, and that's the basis for the whole tractography, and it's very confounding with edema. So using math, Dr. Verma's team was able to correct for that, and these are some examples. This is really nice. I won't go over, in the interest of time, over every case. But just to mention that Dr. Fraser Henderson received the Mahaley-Rosenblum or Rosenblum-Mahaley Award in 2020, Congress of Neurological Surgeons. That was a virtual meeting, but congratulations. And part of that was for the best clinical research for putting all of this together. So. And then Dr. Verma's team also won best paper in neuroimaging of the Society of Neuro-Oncology. But you see, we use this every day. This is more than pretty pictures that is put on the annual report for the neurosurgery department. So case by case, you could see how these fibers, these tracks are validated before and after surgery. These are some nice cases. These are eloquent areas in yellow. Here's the tumor. This is the edema, this cloud. And this is standard tractography, ANC, and this is with with the correction that we just published. And this is the motor area functional over here, the corticospinal tract that is going to that functional area. This is standard, and this is now with the correction. So this has been licensed to one of the companies. I won't mention which company, but it should be available in clinical practice in neurosurgery, and should help. These are some more cases that are illustrious cases. So this is the paper that we need to submit on. This is Fraser Henderson looked at 75 cases that had both ICG and tractography, and we came up. We wanted to put numbers to the concept of oncofunctional balance that Hugh Dufault has championed, and we looked at our cases, and all had neuronavigation, and these were all selected for ICG. Many had DTI and tractography, and about 1 out of 5 had electrical stimulation. So we came up with this score, oncofunctional score, which is adding extent of resection, which is a prognostic factor well known, and KPS, which is prognostic factor well known, and seeing what would be optimal. Of course, it's going to vary for each case. If someone comes in with a low KPS, or for reasons we can't get all tumor out, they'll get a low score. But what we'd like to do is came up with this 80-80 rule, that you'd like to have a patient who's functional, maybe with some effort. That would be a KPS of 80. And you'd like to get over 80% of the tumor out, because that would be, that's beyond the threat. That translates to increased survival, and that's the threshold that that Mitch Berger has shown to be translatable to increased survival. So that's where we're going to put this as and it's not a hard and fast rule, but that's sort of a guideline.
And Dr. Brem, I don't have a question per se, but I thought a couple people in the audience are Dr. Kakia and Dr. Lindhorst, who are neuro-oncologists. I don't know if they want to chime in with any comments on what they've seen for that oncofunctional balance. And they may not be able to unmute, I'm not sure. Yeah, okay, sorry, carry on.
So now, speaking about war and the war metaphor, I knew our program had arrived when we developed CAR T-cell with Carl June, and this was on billboards throughout the city of Philadelphia as American flag, and it's actually very clever, because you have to think of opposing forces. When a mutation attacks the brain, it's called brain cancer, and when the body attacks a mutation, that's the revolution. So long live revolution. So now we it was a mixture of amazement and pride and when I saw this, but anyway, we're going to be opening up the CAR T-cell program is moving along. Dr. O'Rourke is leading that with Dr. June, and Fraser Henderson. I think I know for sure you had another paper accepted that I didn't. It isn't published yet, but it's a case report of a patient with a very long, durable response to the CAR T-cell. And it was Christine Brown's work at City of Hope and published in New England Journal at the end of the year 2016, about 5 years ago, that showed an amazing case, a patient with glioblastoma who had dissemination throughout the brain and the spinal cord through CSF metastases. And that patient would certainly be hospice patient, and that patient had a 7-month complete resolution, complete disappearance of the tumor with CAR T cell to IL-13 was the epitope. So that kind of a case, although it's not, we want to generalize it to everyone with glioblastoma, but that certainly does spur and stimulate, and that just opened up the field. So there are now several hundred CAR T cell throughout cancer, and many in glioblastoma. So many centers are opening up CAR T cell programs. This we're about to open up a program jointly with Dr. Andrews from MVAX, and looking at a protocol where patient's own tumor is harvested and placed in the abdomen, so that one of the problems that with CAR T is that only 30% of patients have that neoantigen, the EGFR-V3 variant, and that during treatment there's immunoediting, there's T cell trafficking. It works, it knocks out that antigen, and the cells just they become resistant or escape, and then use other oncogenic drivers. So the oncoplasticity, the variations within the glioblastoma, the heterogeneity, and the immunosuppressive environment are all barriers that we have to overcome. So in this was just published in Journal of Immunology with Andrew's group, and they looked at this combines and our understanding of angiogenesis with their understanding of immunology. And here's a tumor, and they found, and this was all anaplastic astrocytoma. So these are grade 3. They're malignant, but not fully vascularized like glioblastoma. And the ones that are IDH1 mutant tend to be non-enhancing and are slower growing and have a favorable immunity systemically, type 1. So they'll have fewer cytokines, fewer immunosuppression. But and they will have 5 to 7 year progression. They'll become the full glioblastoma. Another type this is the angiogenic switch that Dr. Folkman talked about, and I wrote about when I was a student and a resident. We could see low grades, or we could see that first patient, Susan Dell, with the low grade non-enhancing or intermediate grade becoming highly malignant. And Doug Honahan then with Weinberg wrote the hallmarks of cancer, the angiogenesis as well as immune escape are two of the hallmarks of cancer. So you see these tumors, these are from actual clinical cases. Becoming the ones that are IDH wild type are angiogenic, and will have in their tissue, they'll have the M2 macrophage, and they'll be immunosuppressive, but also, and these are the bad ones, the myeloid-derived suppressor cells that go to a tumor. And I didn't realize this, but up to 40% of that tissue mass when you take out a glioblastoma is actually microglia or macrophage. So these tumors contain these cells, and these cells create, Amy Heimberger showed this very nicely, create like a wall, and so convert, even if there are lymphocytes there, the lymphocytes are fatigued, the lymphocytes are inactive, they're suppressed, and the glioblastoma is an immune desert. It's a cold tumor. So and then angiogenesis again is linked to the immune response. They did survival and looked at the ones wild type and look at the ones that have the mutation, and of course the ones that have the mutation are have a totally different Kaplan-Meier survival curve, and have all of the features of an immunologically sensitive tumor. So we're trying to take this, exploit this knowledge, and work on a vaccine that also was published in Clinical Cancer Research by his team. Is now going to become a large national trial. This is pre-op. The tumors that you can see, some of these tumors are multifocal and are just very bad tumors. And then after they get the vaccine, they're getting durable responses. So hopefully this is the future, and hopefully we're turning the tide in this war that's been going on for about 40, 50 years. Another way to overcome the blood-brain barrier is the electrical field, which is, I guess, if you look the last 40 years, there's only been 3 or 4 agents that have received FDA approval and increased survival. One is Avastin, which only increased progression-free survival, and some feel that that was just an artifact that, but did not increase overall survival. There's gliadel wafers, which were designed by Henry Brem at Hopkins to circumvent the blood-brain barrier and give local therapy. And then there's 2 therapies pioneered by Roger Stoops. One is temozolomide, which everyone uses, and which can cross the blood-brain barrier. It's part of the 3% of oncology drugs that actually cross the blood-brain barrier. And then there's this electrical field, the Trident. And so we're going to be, Penn is going to be one of the centers with this new trial that will combine radiation and temozolomide with electrical field therapy. I'm very excited about a trial that's coming out of Penn. This came from an observation that I made with the scientists at Moffitt. We did a non-biased study asking the question, why do older patients seem to get more virulent, more common tumors? And so we looked at 5,000 samples from the Genomic Institute at Moffitt and 10 different sites: breast, pancreas, lung, usual sites, melanoma. And in glial tumors, we found that there was one, it was called senescence-associated gene expression, that as patients get older, there's more inflammatory markers and there's more gene expression. In particular, the keystone cytokine is IL-6. And so that also correlated with progression from a low-grade glial tumor to a high-grade glial tumor. And it also inversely correlated with age. Yi Fan and Steve Bagley at our institution validated this, looked at the TCGA, and they found the same data that we had published. And Yi Fan developed this into a laboratory model that was published in Nature Communication, because he found a beautiful mechanism of M1, M2 polarization, that if you block IL-6, you move the myeloid cells to an M1 immunostimulatory state, whereas IL-6 by itself is known to result in the M2 state. And he's shown its different models. And there was a group in Northwestern that extended this work and showed the link with myeloid-derived suppressor cells, and showed the link with PD-1 inhibitors. So our trial that now will go nationally through NRG and open this summer will involve 3 different modalities, because one of the things we've learned is that we're fighting a very tough foe here. As this war in Afghanistan, it's not just one soldier, it's a combination of forces we're fighting: the terrain, the actual soldiers, many things, the whole environment. And with cancer, it's probably not going to be just VEGF or just IL-6. So we're going to attack PD-1, we're going to attack IL-6, And we're also going to treat the tumor with radiation, which opens up the blood-brain barrier and releases neoantigens through abscopal effect. And this works in animals, presumably converting a cold tumor into an inflamed hot tumor, so that we can make the GBM a little bit more, in terms of its immunogenicity, more like those melanomas that respond to checkpoint inhibitors. So, and I'm proud to, as a surgeon, to contribute tissue to all of these scientists who are doing the genomic analysis and be part of a nexus. And you've got some great work going on at the Hollings Institute in CAR T-cell and immunotherapy that everyone there who's interested in tumor should be exploiting. So this is a slide that Fraser Henderson, I'm plagiarizing from him. This is from our discussions. So thank you. I love this. This is looking at the three things that have worked. The temozolomide trial, tumor treating fields, both of these are Stoop. Polymers have worked. And we're hoping to, get into that league. That's our dream, and that's when I can retire, when we move the survival curve to the right. And we're hoping that this is somewhat this is on that Gartner hype curve, but it's also a hope. So that anti-IL-6 and immunotherapy will get into that top tier there. So that's Steve Bagley, who is the first, is the lead on that protocol. It's now called Brain 10, and I'm the neurosurgical chair of that protocol. We have not yet submitted it to New England Journal. All we need is the data, Fraser. All we need is data. So rethink. Time is up. Just rethink, and I'll let you go to the lab. Just want to conclude with a couple of thoughts. So even Doug Hanahan, who did this beautiful classic paper with Weinberg on the hallmarks of cancer, picked up on this theme of the war in 2014. And he said, we have to rethink this whole metaphor of the war on cancer. And in the past, the paradigm was we're going to hit one of these just because these are the Achilles heel of the cancer. We'll block angiogenesis, or we'll look at EGFR, and billions of dollars, years, decades of years, and unfortunately hundreds of thousands of patients have died with this mono, this focus. So now it might be hitting it here, and this 1, 2, 3 punch. The way you fight a war with the Army, Navy, Air Force, all sorts of special forces, Navy SEALs, etc., and combined. In fact, the only thing that worked in the Afghanistan war was a surge. And when you think, look, we're still wearing COVID masks, but I bet most of you are immunized, which a year ago was astounding. That'll take 10 years. So I'm hoping with Joe Biden president, between the Barack Obama years and his current living in the White House, he was at Penn. He knows all about CAR T-cell. He knows all about the immunorevolution. And if you heard the State of the Union address, he really wants to put a lot of dollars into biotechnology. And the day he announced his nomination, he said, I want to be the president to cure cancer. Well, Richard Nixon had that same idea 50 years ago, but our science has matured a lot. So I'm hopeful that maybe it won't be before I come down to South Carolina and visit you guys. I hope I get to do that before, but maybe, who knows? I'm hoping that we will find a formula. A lot of labs are working on it. And you can see with COVID-19 that when people work together and they get out of the silos, when they collaborate, when there's industry and academia partnerships, and when there's money, Now someone will say, yeah, but look, there are variants, and glioblastoma is always, there's so many variants, and it is going to be tough. But I think there's excitement again this year. So this again, Dr. Henderson, one of your slides, and I behind me, I don't know if you can move the camera to my office. He or his family made a modern day, merged these two to show the Agnew Clinic with navigation. So the best is yet to be, and I just feel very grateful to the family. And then I give a talk to the medical students, and I'm reminded today the big issue is life-work balance. How do you get that life-work balance? If you're interested in academics, go to a very good place, get the fellowship, get those KO8 awards, work in the lab, get promoted, get your grants, and keep publishing top journals. And one day you'll be a professor and keep working. If you're in community practice, just be the best you could be, work very hard, develop a reputation, and get a large clinical practice. And then one day this is a lifestyle that your children will enjoy. Thank you very much for this.
Thank you very much, Dr. Brem. There's a lot, I mean, we could talk for hours about this, a lot to unpack, but I wanted to give the neuro-oncologists an opportunity to say anything or jump in as they're remote. Dr. Kiki was saying he had trouble with muting, but feel free.
Can you hear me? Can you hear me?
Yeah, we can hear you.
Hi, Dr. Brem. Thank you for the excellent presentation. I'm one of the neuro-oncologists, as Fraser has said, here at MUSC, and I think the talk was spot on about where we are in the field right now. I wanted to get your thoughts. Obviously, immunotherapy has revolutionized oncology in general, but unfortunately not yet in our field. Melanoma was in our same sort of situation 10 years ago, especially metastatic melanoma, poor prognosis for these patients, and now they have these very efficacious drugs that patients are living years out. And unfortunately, we're not there yet in our field. But when you look at the data in our field, right, for immunotherapy, so far overall it's been disappointing, but we all see those few select patients in these trials that are living for a long time. So one is what is different in those patients compared to the rest of the cohort that these trials that these patients are eligible for. The other question, I think, is also the timing of these drugs. When should we be giving these drugs? There was a paper published in Nature Communication where they gave immunotherapy neoadjuvant before surgery through UCSF. It was Tim Clousey and his group there. And, it was obviously an early study, but it showed promise. So are we mistiming when to give these drugs? When should we be giving these drugs to get the best outcomes for our patients?
Those are two great questions. We had Christine Brown visit us, and she talked about that one patient who did very well, and they got some tissue, and they did like transcriptomics on that patient, and that patient probably had very few oncogenic drivers and was not as polyclonal as some of the other tumors. And so with all types of therapy, including immunotherapy, there are those that are more responsive and those that are less responsive. But I think that's the key. We don't have a good test. We don't have a good agent that works for the vast majority of patients with glioblastoma. But when we do, we'll have responders and non-responders, and it'll have to do with the heterogeneity is a big problem. which goes to the second issue of timing. You know, again, when I was a student resident years ago, 70s, 80s, and 90s, HIV was a horrible disease. And there's Dr. Fauci who solved it with others, of course, NIH, armies of people. But what they there you have viral load, you have biomarkers, you have CD4, CD8 counts. You can tell whether a drug or a drug combination is working. Then you can stop. In oncology, as you know, we use survival as an endpoint, or our radiological markers, which I just touched on with F18, progression versus pseudoprogression. Our brain tumor conferences, we're really not sure. Is it working? We have a paper out now in Clinical Cancer Research, just came out with Ben Ellickson about the modified RANO, the iRANO, the regular RANO, and using the modified RANO technique, we can tell a drug to IL-4 receptor is working, but not with the other criteria. So our methods of assessment are, that's why our timing is very arbitrary. And that's another reason, that's a very big barrier to progress. So at Penn, Steve Bagley has worked with Erica Carpenter on liquid biopsies and is doing cell-free DNA, and has published several papers on that. And hopefully that'll be, you know, that's the holy grail right now. Because if we knew something was working, we would continue till we got a great result. And if it wasn't working, we wouldn't be exposing the patient to ineffective toxic therapy.
Thank you, Dr. Brem.
Thank you.
Dr. Patel just had to sign off for a meeting, but he wanted to especially thank you as well for spending this time with us. And we'll circulate a menu to you to think about when you come down, and I'll assign you a couple of interns who will drive you around. So thank you again, Dr. Brem. And unless anyone else has any other comments, I think we'll sign off.
Thank you for this great honor. I appreciate it. Bye-bye.
Bye.